Dr. Kenneth Liegner is an author and a treating physician, and he's been at this a long time. Please enjoy.
Can everybody hear me? Thank you all for coming out on a Saturday. And I want to thank Bob Sabatino for inviting me here to speak. I first met Bob a couple years ago at the first Lyme Innovation Hackathon at MIT, right? Yep. In Boston, at a place called, I love the name, the Nerd Center. Right. Okay, it's not what you think. It stands for New England Research and Development, right, of Microsoft. But anyway, that's where I met Bob.
Hey, we're nerds.
And I know that, I gather, I don't really know all the details of it, but Bob, you have suffered a lot and lost a lot from Lyme, right?
Yes.
And I think it's great that you started the society. And it is, you know, this is the first meeting, and I'm sure you're doing this like a lot of other people, like Pat has done, starting the Lyme Disease Association, so that to educate people, to advocate so that other people don't have to suffer in the way that you have suffered. Okay?
100%.
And the other thing is that I appreciate law enforcement, the important job that law enforcement does, and it really is a thin blue line out there. So thank you.
Thank you.
And I'd ask you this, Bob, in your career of law enforcement, what's more dangerous? The perps you've encountered or the ticks you've encountered?
I'm going to say the ticks. At least the perps I could kind of profile them. You can't profile a tick. You don't know what's in that gut.
Okay. So I'm going to talk about the disease that doesn't exist. Okay? Chronic Lyme disease. Chronic Lyme disease is unbelievable. You know what? It really is unbelievable. If you didn't experience it yourself or have a loved one who experienced it, or if you were, unless you were a healthcare practitioner who really listened to their patient and carefully followed them over time, you wouldn't believe it. And I actually don't blame people for not believing it, because it really is an incredible illness. First of all, physicians must rely on their powers of observation and their careful study of patients over time and in response to treatment interventions, and also behavior of the patient while they're off treatment. You can learn both from treating and from observing. A physician's most precious possession: professional autonomy. Your ability to use your own independent medical judgment. It's critical. I want to talk about ideology versus science. Ideology is a belief system, okay? And ideology can be very powerful. And it also can be a lens that affects what one sees and how one interprets what one sees through the lens of an ideology. It's also not unusual for an ideology to cohere with the economic self-interest and maintenance of power and authority. A plea to physicians: listen to your patients and also examine them, okay? This is a great book. This was a book by Paul Starr. He graduated from Columbia College about a year before I did, and he's now a professor of sociology and public affairs at Princeton. The Social Transformation of American Medicine. And in that book, he accurately predicted what he called the coming of the corporation, or the corporatization of medical practice, which has really come quite a bit to the fore. Properly caring for persons with Lyme and other tick-borne diseases is time-consuming. It does not lend itself to care within 15-minute appointments. And unfortunately, many of our physicians find themselves caught up in this corporate system. Young graduates of medical schools and residencies Well, it seems great. They finish and they get plugged into a, a vertically integrated healthcare system. They've got an instant practice. They got a nice salary, 150, 200 grand a year. There's only one problem. Those patients, they're not their patients. Their patients belong to the corporation. Okay? One of my patients, Vicki Logan, she's on the cover of my book. She was involved in a lawsuit against Empire Blue Cross Blue Shield. She and about 13 other patients. There was an attorney named Ira Moorer who was the attorney, and he valiantly brought the suit. In that lawsuit, there was very important testimony by one of their executive vice presidents, a guy named Richard Sanchez. And in that testimony, which is public record, it became clear that Lyme disease as an illness and the physicians who cared for patients with Lyme disease were targeted. They were red flagged. Why? To rein in costs. Very, very clear. In that regard, Empire Blue Cross Blue Shield and many of the other insurers were greatly assisted by this. The Lyme disease, the Infectious Diseases Society of America Lyme disease guidelines, they came out in 2000, and they revised them, and they came out again in 2006. And both of them had this basic gist. There is no convincing biologic evidence for the existence of symptomatic chronic B. Bergdorf Ray infection among patients after receipt of recommended treatment regimens for Lyme disease. Antibiotic therapy has not proven to be useful and is not recommended. For patients with chronic, that means greater than 6 months of subjective symptoms after recommended treatment regimens for Lyme disease. Okay, so that has set the tone. And furthermore, the CDC has linked to those guidelines. The CDC site, there are other guidelines that are also approved and have qualified to be on the National Guidelines Clearinghouse, namely the International Lyme and Associated Diseases Society, which has a very different set of guidelines. CDC has stubbornly, intransigently refused to link to both guidelines. They only link to the guidelines that says don't treat, there's no such thing as chronic Lyme. And why is that? It's a really good question. Why is that? In that regard, I think you asked about how come there's not a lawsuit, right? So as a matter of fact, there is a lawsuit. Late in 2017, a group of patients headed by two patients in particular, one named Lisa Torrey and another named David Kosurik, who has since passed away, but his wife is continuing it, and about 30 other patients. This is a story. I didn't know these people before, but Lisa and David, they were disabled, but they were very smart. And they spent about 10 years putting together the elements of litigation. And not too long ago, they submitted all that information to 3 different groups of RICO attorneys, very experienced RICO attorneys. You know what RICO is? Racketeering, Influence, Corrupt Organization.
We're in Staten Island, of course we know.
Okay. So these attorneys who were very experienced, they took all of those materials and they ran it by legal scholars at Harvard and asked the legal scholars at Harvard, is there a case here? Is this meritorious or not? And those legal scholars reportedly got back to these attorneys and said, yes, we think it has merit. So with that, these 3 different groups of attorneys decided to take the case on, and furthermore, on contingency. That's big, okay? Meanwhile, it's still before a judge who has to decide whether or not it's going to move forward. But it is the first time that the people who have drafted these guidelines, it's the first time that they are on the back foot. You know what that means? It's a boxing term. Because up until now, they've had a real sense of impunity. So anyway, we'll see what happens with it. Another thing is the issue of reform in this field and a focus on human rights. When you really get down to it, at basis, this is a human rights issue. There has been efforts to reform ICD codes. You know what ICD codes? That stands for International Classification of Diseases, okay? So for syphilis, which is a similar, infection by a spirochetal disease, if you look in the ICD books, you'll see like a page and a half of codes. Syphilis with this complication, syphilis with that complication. It helps to flesh out the nature of the illness. For Lyme disease, there's like 4 or 5 codes. It doesn't adequately represent the full extent of the disease. So this has been a very big effort. Jenna Luche-Thayer and about an international group of scientists and physicians have all cooperated, and we have advocated for there to be updated codes in the next set of ICD codes, which are going to come out in a year or two. Not just for Lyme, but also for relapsing fever. And there's been a lot of pushback, surprising, because other patient groups, when they advocate, they're usually included. But the Lyme patients, they've been excluded. So it's very bizarre. And then the other thing is Jenna has brought this up as a human rights issue before the UN. Okay, there's what's called special rapporteurs. And there are several special rapporteurs at the UN who have accepted Jenna's reports. And these rapporteurs are particularly involved in the issue of corruption in the health care sector. And they're very, very interested in this. And in fact, Jenna and others are going to be going to Geneva, Switzerland in June to meet with a special rapporteur about this issue. This is Jenna. If you haven't met her, she's got an incredible background in international human rights. Okay, so I don't need to rehash all of this. Lyme disease is a zoonosis. It's a disease that exists in nature, transmissible to man. I'm not going to go into all of the details. I think a lot of you already know this pretty basic stuff. And then, they're classic, what we call pathognomonic manifestations. In other words, if you have the manifestation, it almost makes the diagnosis. The rash, the drooping of the side of the face, arthritis, inflamed joints, heart involvement, meningitis. And of course, everybody's happy if that occurs in a known Lyme endemic area, okay? But there's a lot of areas that haven't been considered endemic. And in addition to those pathognomonic features, there are this wide range of non-specific constitutional symptoms. And just by these, it's very hard to make a diagnosis, but fatigue, malaise, flu-like symptoms, low-grade fever, night sweats, headache, muscle joints, neck pain, body aches. I mean, you could have that with anything, right? You could have that with a viral syndrome. There can be, as Dr. Bransfield talked extensively, there can be neuropsychiatric symptoms, et cetera. There can be sensory hyperacuities. I'm not going to go into that too much. And also a wide and expanding range of multi-system manifestations. So this is a disease that's relatively new to mankind, or at least our knowledge of it is new. So I'm fond of pointing out that for syphilis, it literally has taken mankind 500 years to really understand syphilis and have a good grasp of it, okay? So we're 30, 40 years into Lyme. There's an awful lot that we still do not know. And again, as Dr. Bransfield has said, this is an illness that it often involves multi-system manifestations that can evolve over time, and I'm not going to go over every system, but just about any system in the body can be affected. I also want to point out that there are occasional patients where they don't have that multi-system flavor, where they really have just one type of manifestation, so it's very confusing. It really takes a long time to get a handle on this. And then there are the so-called atypical presentations, no known rash, no known tick attachment, occurring in what are considered non-Lyme endemic regions, although I think at this point every state in the union pretty much is considered to have Lyme. Then you have the patients who don't test positive. They're what we call seronegative or sometimes seroequivocal, or they have Western blots that are not fully diagnostic, or they have an uncommon or one-of-a-kind type of manifestation. And then there can be this state of diagnostic uncertainty, a kind of a limbo, where you really don't know what the patient has, and that's very anguishing for everybody, most of all for the patient. I've found that patients can deal with almost anything once they know what it is. Even a diagnosis of cancer, okay, I have cancer, I'll deal with it. But for many of the patients, there can be an extended period of time where nobody really knows what they have, and even the physician can't really say what they have. Lyme disease has been called the new great imitator by Andy Packner, syphilis being the original great imitator. Then you get into this controversy over chronic Lyme disease. You have competing conceptualizations of the illness. The question, can the Lyme organism persist after application of antibiotics? How reliable are the standard tests in diagnosing the illness? And controversy thrives in the absence of a highly reliable direct detection test that all can agree upon. On the one hand, you have this dogma. Lyme disease is difficult to acquire, easy to diagnose, readily cured with a short course of antibiotics. If the patient has symptoms following treatment, either the initial diagnosis was wrong, or the patient now has post-treatment Lyme disease syndrome because there is no such thing as chronic Lyme disease. On the other hand, you have CATMA. Lyme disease can be difficult to diagnose. The tests are not always reliable. When we treat, we cannot be assured that the infectious agent is invariably eradicated with bacteriologic cure. And some individuals relapse following recommended treatment regimens. The agent of Lyme disease is highly complex and has many stratagems to evade destruction by antimicrobial agents and the immune system. And some cases of Lyme disease can be extraordinarily difficult not only to diagnose, but also to treat with our current methods. Here is PERP 1, the adult female deer tick. This is a picture of adult female deer tick in the palm of the hand. And this is an image of the nymphal deer tick embedding in skin with a human fingernail, just to give you an idea of how tiny these are. And by the way, this is already partially engorged. So it really is the size of a poppy seed. And when you see the nymphal deer tick, it's really impressive how tiny it is. And it's also very easy to overlook. Okay? This is a scanning electron micrograph of the business end of a deer tick. I like to comment that it's an amazing feat of animal engineering, right? And you can understand why it's so difficult to remove an embedded deer tick once they're really embedded. When the tick has fed to repletion and is ready to drop off, what the tick does is to secrete enzymes that basically digest the skin and allow this to just fall out as a plug, you know? This is the undersurface of that, what's called the hypostome. And you'll notice, I don't have a pointer, but you can see those teeth-like projections. Those are what are called the chelicera, and they actually slice through the skin, you know, like a vorpal sword, knickerknack. And it also, the tick also secretes enzymes that anesthetize the skin, so the victim isn't aware that it's attached, number one. And number two, it also, it secretes enzymes that anticoagulate the blood, so the blood can pool, so that the tick can just drink up the blood like a straw. And it also secretes substances that interfere with the host immune response. So tick saliva is pretty amazing, actually. This is an article by Claude Garon and Dave Dorward from the Rocky Mountain Lab. That's part of the National Institutes of Allergy and Infectious Diseases out in Hamilton, Montana. This is from 1989. And they did very important work on the fundamental biology of Borrelia. This is more from that paper, and I just want, the reason I'm showing this is I think you can appreciate the Borrelia have these little blebs that are budding off from the surface, okay? Those are very, very important. This is part of the basic biology of the organism to shed these blebs. And it's not just membrane. Within those blebs is genomic material of the organism. So there may be few spirochetes, but these spirochetes on an ongoing basis shed zillions of blebs. Okay, and I'll get back to that later. And also these blebs they contain that outer surface protein A. They're very rich in outer surface protein A, and outer surface protein A is both highly immunogenic, it can stimulate the immune system, and it also can cause immune suppression. This is Public Health Law 96-517 from December of 1980. Does anybody have any idea what that is? You probably don't. It's a kind of a trick. This is what's called Bay-Dole, B-A-Y-H-D-O-L-E, that was from Birchby, and Bob Dole. This was a law, an amendment to the patent law. And let me just give you the background on this. So the National Institutes of Health, the federal bureaucracy was giving millions, tens of millions, hundreds of millions of dollars to research. But what was happening, the results of that research would be just kind of sitting on a shelf. Nobody did anything with it. So this law, which was well intended, was to incentivize the people who developed these tests. So what it allowed is that people who got federal grants and certain agencies were able to patent their inventions and then profit from them, and that was in order to move them out into the commercial realm so that they could benefit people. So it was actually, not a bad thing. So this was 1980, okay? So this is an article from 1982, which is the first demonstration that Lyme was caused by a spirochete. This is the publication from Willy Bergdorfer around 1981 or 1982. So you have Bay-Dole in 80, 81 or 82, the Lyme organism is discovered, okay? B. Bergdorf Ray arguably is one of the most, if not the most, complex bacteria known to man. And arguably, or maybe inarguably, the most heavily patented bacteria known to man. And that has, I think, important implications for public policy. I'm going to let you know of what I regard as my, quote, sacred texts when it comes to Lyme disease. One is a slim volume by a guy named Oscar Felsenfeld called Borrelia. This was published in 1971, before the Lyme organism was even discovered, and he was talking about other Borrelia, what are called relapsing fever Borrelia, and I didn't realize it until I was preparing for this talk, because I looked at the frontispiece on this book, that Felsenfeld was, he was a professor of communicable diseases and tropical medicine at Tulane University, Tulane University Medical Center, and at that time he headed what was then called the Delta Primate Center. And I didn't realize that no doubt has got to be the forerunner of the Tulane National Primate Center, where some of the great research on Lyme disease is being done. Like Dr. Fallon told you about the rhesus monkey studies. Well, this is also out of Tulane, so we'll get to that in a bit. Also, you want to try to have a handle on Lyme and get some understanding of Lyme disease? Well, learn about syphilis, okay? You want to understand Lyme and what Lyme can do? Read about syphilis, because we have much more literature on syphilis. So this is from a textbook of modern clinical syphilology from 1928, okay? This was before antibiotics were even discovered. But this is so rich in the manifestations of spirochetal disease. And also, there's a chapter in this book, and in fact, I've made this chapter available to some of my colleagues in ILADS and elsewhere, on the clinical approach to the diagnosis of syphilis. The remarkable thing about that, if you read that chapter, the clinical approach of clinicians towards syphilis, turns out it seems so familiar to me when I realized that it's very analogous to those of us who care for patients with Lyme disease, a similar kind of approach, a very inferential approach, trial and error, observation. Okay. This is another great book. It's a monograph by a guy who I imagine he's long since dead, J. Lawton Smith. He was at Bascom Palmer Eye Institute of University of Miami, and he did fabulous studies, and the title says it all, Spirochetes in Late Seronegative Syphilis, Penicillin Notwithstanding. So, there's precedent for spirochetes to survive penicillin. Is it really that unbelievable that Borrelia might also not succumb to antibiotics? There's already precedent for it. This is also a great book. It's from the New York Academy of Sciences. It was published around 1988. It's really just packed with information. One of the first things that I read in depth, and I still have it on my bookshelf. I've also been very blessed to work with wonderful colleagues during the course of my career. Brian Fallon, who was here speaking earlier, this is a couple decades back. We were all a little bit younger at that time. And also Dave Dorward from the Rocky Mountain Lab, a wonderful researcher. And Claude Garan, who was the chief of microscopy at the Rocky Mountain Lab, he was kind enough to invite me out to the lab maybe 10 or 15, probably 20 years ago. Behind him are the Bitterroot Mountains of Montana, beautiful. His wife is to his right, and to my right is my father-in-law, Tadashi. And Paul Duray, wonderful scientist, one of the top pathologists in the world, and I was so lucky to be able to work with him and study my patients. He's since passed away. And Alan McDonald, who still is living, but he's retired, and he's done fabulous work, pioneering work. He's always been 20, 30 years ahead of everybody else. Because why? He's a pathologist, and he has studied Lyme directly. Patricia Coyle, who is still at Stony Brook. She has done some of the really fabulous early work in Lyme disease, and we'll get back to that in a little bit. And also Steve Schutzer. He and Coyle both did wonderful work in Lyme disease and continuing. Dorward and Garan and Tom Schwann did more than just study the organism. They actually developed a test, a direct detection test for Lyme. And what it did was, remember I showed you those blebs that shed? They developed a method that, although it was labor intensive and required electron microscopy, directly detected the blebs shed by the organism. And they studied it in different fluids and in different animals, and it was very convincing, okay? The problem was it was not very suitable for what we call high throughput commercial laboratory, because you can't do electron microscopy on clinical specimens. You could use it for research. So back around the late 1980s, early 1990s, I didn't mention the pictures of those deer ticks that I showed you. Those were taken by a gentleman by the name of Derlin Fish. He was the director of medical entomology at New York Medical College, and it turns out when I set up my practice, the headquarters of New York Medical College Department of Entomology was about a quarter mile away from my office. So Derlin and I got to be friendly, and that's how I got those pictures. And also, he introduced me to folks from CDC. And they knew that I was evaluating patients who either did or who might have Lyme disease, and they were keenly interested in it. And they asked me to send to them specimens from the patients I was evaluating, blood, urine, and also spinal fluid from my patients. So for maybe 2 or 3 years, I sent them hundreds of specimens from my patients. I had no idea what they were going to do with it, okay? But I later found out what they did with it. Well, a lot of the specimens that I had, they forwarded on to Dorward and Garan at the Rocky Mountain Lab, and I'm one of the few clinicians whose patients actually were subjected to tests using that method that they developed. And this is a chart that Claude Garan put together of the specimens from my patients. There were 51 specimens. There's a column that says RML. See that? That stands for Rocky Mountain Lab. That's that direct antigen detection, looking for the blebs shed in the urine. And then, excuse me, to the right, there's 3 different blood tests, ELISAs. TQ stands for Tom Kwan. He's one of the scientists at the CDC Fort Collins in Colorado. Then there was a sonicated ELISA and a flagellar ELISA. I'm sorry. So what I want to bring to your attention is the most, one column in particular, this one right here. There were 37 patients who tested positive on the Rocky Mountain Lab antigen capture assay, and guess what? They tested negative on all of the serologies, okay? So to me, this was a clue. I'm good, I have it, thank you very much. This was a clue to me that there's a deeper reality to this disease that's not being captured by the 2-tier system of testing, okay? And we actually reported on this at the 5th International Congress on Lyme Borreliosis in Arlington, Virginia. And This is the title, Lyme borreliosis studied with the Rocky Mountain Lab antigen capture assay in urine, with my names on it, my name and Dr. Garan and Dorward's. And this was the conclusion. Study results from this direct antigen detection method suggest seronegative Lyme borreliosis is not rare and lend support to the hypothesis that B. Bergdorferi can persist in the human host despite intensive antibiotic treatment, because many of these patients had gotten very lengthy courses of treatment. The other thing about this group of patients, they had an incredible variety of presentations, really, like just much beyond the usual things that you look for. One of them was a young woman who came from a town not far from where I now practice, who had a rash on her thigh, and I don't think she tested positive on the standard test, but she did test positive on the Rocky Mountain Lab antigen capture assay. She went on to develop something called pulmonary hypertension, or they sometimes call it idiopathic pulmonary hypertension. Despite my treating her, because I suspected that she might have Lyme, but I couldn't prove it until after we had these tests. Unfortunately, her pulmonary hypertension got so severe she ended up in the ICU at the Mount Sinai Hospital in New York, or the cardiac CCU, and unfortunately died from her pulmonary hypertension. And that's unfortunate, of course, but even more unfortunate is that the physician responsible for her did not request an autopsy, because we could have learned a lot from her case. It's tragic, a lovely young woman. The Rocky Mountain Lab antigen capture assay, this was big news. It was in the New York Times, more accurate way to detect Lyme disease may be near, okay? So what happened to that test? Well, the NIH really didn't support it. They did license it. One of the laboratories tried to take it on and see if they could adapt it to something that would be suitable for high throughput commercial use. They had it for a year or two, spent a lot of funds, and they just couldn't figure out a way to adapt it, and then it reverted back to the NIH, but the NIH did not support it. I mean, at least it could have been used as a research tool, but it's almost like, they don't want to know for some reason. Okay. Getting back to Steve Schutzer and Pat Coyle, they also developed a range of novel tests. One was looking for what's called Borrelia-specific immune complexes in different bodily fluids. And they were able to determine that some people had antibodies, but the antibodies were bound in what are called immune complexes, where the antibody and antigen was bound together. So unless you use special methods, you wouldn't see the antibodies. And then they also developed a method of direct detection of antigens shed in the spinal fluid by direct detection, what they called antigen capture assay for outer surface protein and also outer surface protein C. So again, due to fortuitous circumstances, I had the opportunity to submit 140 spinal fluids on my patients to be tested through their methods, which was being done on a research basis at Stony Brook. So this is a printout of the results, and this grid was produced by a woman by the name of Priscilla Munoz, who was the research supervisor at that research lab. And all the positive results are highlighted in yellow, okay? And to the left, only 2% of the specimens tested positive on the standard antibody assays, but when I used all of the different methods, the OSP-A antigen capture, the OSP-C antigen capture, and the Borrelia-specific immune complexes, IgG and IgM, 61% of the specimens tested positive. So again, because I had access to these research tests, and let me tell you, these are not lightweights. These are some of the finest biomedical researchers in the world, okay? Again, to me, there's a deeper reality here, not captured by the standard methods. And again, for reasons that are unclear, these methods have all been mothballed. It's tragic. They could have been available for 20, 30 years. They're all mothballed. And for some reason, the CDC is continuing to promote the two-tier method of testing. It's crazy. Okay. Furthermore, it has become clear that the Lyme organism is not just outside the cell, it also goes inside the cell, okay? This was a study done by Mark Klempner and Kostas Georgilis. And what it showed, they used a method called laser confocal microscopy, and what that does is it allows you to go through the cell micron by micron, okay? What they were able to demonstrate in a cell tissue culture of fibroblasts was that the Borrelia spirochete were actually inside the cell, okay? If they treated the culture with the most potent antibiotics known to man, ceftriaxone, which is commonly used to treat Lyme, then they washed off the ceftriaxone, lysed the cell, Borrelia was liberated, okay? So this is a hell of a complicated infection, okay? This was in fibroblasts, but this is a picture of a woman named Jill Livengood from CDC Fort Collins. So they're wonderful scientists out at CDC. They do great things. So Jill Livengood and Robert Gilmore from CDC, well, they did the same thing, not just in fibroblasts, but in cells that make up the cells of the nervous system, human nervous system, neuronal cells and glial cells. They found the exact same thing that Klempner and Georgilis found, that they could liberate Borrelia from within these cells even after treating the cultures of neuronal and glial cells. So this is one heck of a complicated organism. This is a picture of Reinhard Straubinger. I can't take questions right now, maybe at the end. Reinhard Straubinger is a wonderful researcher. He was up at Cornell Vet School. To his left is someone by the name of Jarmo Oksi from Finland. He's an excellent infectious diseases researcher from Finland. But Reinhard Straubinger took a beagle dog model of Lyme, and he was able to demonstrate in that beagle dog model that despite application of antibiotics, they could detect evidence of Borrelia in the dog, okay? This is, a couple decades ago. This doesn't project very well. This is a gentleman named Emir Hodzik, and he demonstrated the same thing in mice, okay? But you need special methods. You have to really want to find it, and you have to use special methods, and also you have to follow the mice. So the mice were treated, they couldn't find the organism, but like close to a year later, if you continued to follow, they were able to detect re-emergence of Borrelia. So this is one tough organism to kill, and or our antibiotics, maybe they are suppressive, they're not eliminating the infection. This is Nicole Baumgarth from UC Davis. She has done wonderful work in a mouse model of Lyme to help us understand how is this possible. And she's had a series of articles on the behavior of Borrelia in mice. And basically what she has shown is that Borrelia really messes with the immune system. So unless you were a pathologist, you wouldn't know this, but in lymph nodes and in the spleen, there are what are called germinal centers, which are three-dimensional little spheres, and they're organized in a very specific way, and that enables the immune system to develop antibodies, and also that enables the normal sequence of development from IgM, which is the early immune response, to IgG. Okay, that's the normal sequence of events. But in the mouse model, the Borrelia, basically it's like putting those germinal centers in a Waring blender. The architecture is completely disrupted. And then the mice do not go on to develop that class switch from IgM to IgG. And many of us who are caring for humans with Lyme disease see the same thing, where many of the patients who are seriously ill with Lyme disease never make that switch from IgM to IgG. And then they don't have antibodies, so they can be seronegative. Meanwhile, the CDC and the Infectious Diseases Society of America are telling everybody, ignore the IgM response except in the first month or two of illness. And that's not what us clinicians see. We see persisting IgM, and we often see what we call an expansion of bands over time, which is indirect evidence of persistence of infection. And this is all being denied by CDC. This is Monica Embers. She's the researcher who's at Tulane. They used to call it Tulane Regional Primate Center. They now call it Tulane National Primate Center. I think that's the descendant of the Delta Center that Felsenfeld worked at. And she's done fabulous work in this rhesus monkey model of Lyme. She's published several papers in 2012 and also in 2017. And what she basically was able to show was that despite antibiotic treatment, if you look at the tissues, the Borrelia are there in multiple tissues. And the other thing that she found in her latest study is that the antibody test results did not correlate whatsoever. So the test could be positive, they could be negative, but in the tissues there are Borrelia. So in other words, you cannot rely on the antibody tests. And that's why direct detection methods are so important and need to be supported, and they're not being supported. Even now, they're not being supported. Okay, that's all about in animals. What about in humans? So in 1989, Vera Priek-Mursik from Germany published on recovery by culture of Beryllium Bergdorf Ray in patients who had already been treated with antibiotics, including intravenous antibiotics. So this is a real landmark article, okay, the first of many to follow. Beautiful work that she did. A couple years later, this is also from Europe. This was from a patient who had had Lyme disease, had gotten treated, including IV antibiotics, who later developed inflammation of one of the flexor tendons of her finger. They did surgery, removed the inflamed tissue, and when they looked at the tissue under the electron microscope, they found this. So these are collagen, the striated are collagen fibers, and nestled in between the collagen fibers is Beryllium Bergdorf Ray. So this Lyme organism just loves dense connective tissue. And the other thing it shows, which is not so clear, but it shows that the Borrelia was actually going inside of the fibroblasts, just like in that study that Georgilis and Klempner had done. Okay, I'm going to tell you about one of my own cases, famous case of pediatric ICU nurse Vicki Logan. So let me give you the background on her. So she became my patient late 1980s. She was referred by another patient. She was a pediatric ICU nurse, and for several years before she came to me, she had developed a gait disturbance where she would be dragging her foot. And when they looked at her spinal fluid, she had a lymphocytic meningitis. She had what they call a chronic meningitis. She was studied by many practitioners, many different medical centers, some of the top people in the country. Nobody knew what she had. She came to me, and I didn't know what she had. I did every test that I could do, all the Lyme tests. I could not make a diagnosis. I referred her to many of my colleagues, rheumatologists, neurologists. Nobody knew what she had, and neither did I. At the end of a year of careful study, I said to myself, I don't know what she has, but I cannot exclude Lyme disease. I knew that she had grown up in a little town in Westchester County called Golden's Bridge, which is tick-infested. But she never had any known tick rash, never had any known tick attachment, never had any known rash. I decided to admit her to hospital. I did a spinal tap on her and then treated her with 3 weeks of intravenous cefotaxime, which is one of the most powerful antibiotics to treat Lyme. After the treatment, I retapped her. There was really no change in her spinal fluid, and her condition didn't improve. And I gave her a couple of months of oral antibiotics, condition didn't improve. And at that point, I just kind of backed off. I figured I'd given her the benefit of the doubt, and I didn't really know what she had. And and then about a year later, she contacted me and begged me for a spinal tap. So you can imagine how desperate people would be to have to beg for a spinal tap. But at that time, actually through Derlin Fish, I was working with folks from the CDC. And the folks from the CDC provided me with something called BSK2, Barber, Stoner, Kelly 2 culture media, where with luck, sometimes you can actually grow the Lyme organism. So this second time that I tapped her, maybe it wasn't the second time, but in December of 1991, I tapped her, and this time I had the BSK2 media, and I put a couple cc's of her spinal fluid into the BSK2 media. And then a couple of weeks later, I got an excited phone call from David Dennis from CDC Fort Collins to let me know that spirochetes were growing out of her spinal fluid. okay? And David Dennis, he was incredulous because he knew that she had previously been treated with treatment that's supposed to cure the disease. And he said to me, which I didn't really get offended. I could have been offended, but I wasn't offended. He said, Ken, are you growing Borrelia in your office? In other words, that's why I say chronic Lyme is unbelievable. I mean, I wasn't offended. It was just, I say this because it was so hard to believe that this is possible. But it turns out, not only were they spirochetes, they turned out to be Beryllium Bergdorf Ray. And this is the actual culture report from CDC Fort Collins from probably it was 1990, well, the specimen was 1991. They probably didn't report it until January of 1992. And this says, identity B. Bergdorf Ray isolate confirmed by PCR. And Roy Campbell is one of the folks at CDC Fort Collins. Okay, and we did report this at the 5th International Congress on Lyme Borreliosis in Arlington, Virginia in 1992. This was the title, and you can see my co-authors are folks from the CDC. So this is from the CDC itself, okay? And the conclusion was this. Culture of this CSF specimen in BSK2 yielded a strain of B. Bergdorf Ray. Culture-confirmed treatment failures have been previously reported from 3 Lyme neuroborreliosis cases in Europe. The present case, apparently, is the first of this type to be reported from the United States. Okay? This made the headlines of the New York Times, Science Times in 1993. And that's me at Vicky's bedside, taking a photograph taken by a New York Times reporter. It's on the cover of my book, and trust me, I had to pay dearly for the rights to put it on the front of my book. I published about her. This was a guest commentary in the Journal of Clinical Microbiology. I just want to, I love this quote, so I'm just going to mention, disease is very old, and nothing about it has changed. It is we who change as we learn to recognize what was formerly imperceptible. This was from Jean-Martin Charcot, who was one of the world's famous neurologists from the Salpêtrière in Paris. We also published her case in the Journal of Spirochetal and Tick-Borne Diseases, along with other cases. I want to tell you what happened after I learned that she really had Lyme. So before, I didn't know that she had Lyme, but now I knew that she had Lyme. And this time, I treated her not for 3 weeks, but for 13 weeks with intravenous cefotaxime and what we call a pulse regimen, where she treated like 2 days a week for 13 weeks in a row. And with that, guess what? Her spinal fluid that had been abnormal for 5 or 8 years completely normalized. The white cells went away, and her condition modestly improved. I mean, it wasn't perfect, but it improved. And at that point, you know what? I didn't know what to do. I didn't know what else to do. I stopped treating her, and guess what? She started gradually going downhill, and I wasn't sure what to do with her. She also had a condition called spasticity, where her gait, her muscles were very, very tight. It was difficult for her to walk. At that time, the Mayo Clinic was one of the few places that offered something called a baclofen pump. That was a new Medtronic pump. It was very new at the time, and we sent her out there to see whether or not she would be a suitable candidate for implantation of a baclofen pump. When she got out there, they gave her a test dose, but what happened, they just gave her an individual dose in the spinal fluid, but what happened was, turned out that she needed the spasticity to be able to walk, and without that spasticity, she was even less functional. So they decided not to do it. But while she was out there, she came into the hands of one of the rheumatologists out there. And by the way, she also had some markers of autoimmunity. She had a positive ANA and low positive anti-double-stranded DNA antibodies. So the doctor out there said, well, maybe she has Lyme, or she has Lyme, but we think, she really has something else, that's what, So what they did is they gave her 10 days of intravenous ceftriaxone just for good measure, and then on the premise that this was really a primary autoimmune disease, they gave her high-dose steroids for a short period of time. And then they sent her back to me in New York. she was a mess when she came to me in New York. She was very deteriorated. She could not hold a cup, could not roll over in bed. She was having difficulty protecting her airway. She was actually aspirating. And it actually looked like she was going to die. Also, when we admitted her, we discovered that for the first time, she had an accumulation of fluid around her heart and in her lungs. And if the fluid around the heart gets too much, it can cause a condition called cardiac tamponade, where the heart cannot beat and people can die. So both for diagnostic and therapeutic purposes, I had one of my colleagues, a cardiovascular surgeon, create what's called a pericardial window, where they take a coin size, like a 50-size cent piece of tissue of the pericardium out that allows the fluid to drain into the chest cavity. The head of, the vice president for medical affairs at my hospital happened to be an infectious diseases physician. And just around that time, he called me on the carpet. And he said, "You're obsessed with Lyme disease." And it was clear he was getting ready to sanction me. He was getting ready to sanction me. Very fortunately, just before that, I got the report of the pericardium from my colleague Paul DeRay, who was at that time at the NIH. And the pericardium showed a dense infiltrate of cells, including what are called plasma cells, which you often see with spirochetes. And not only that, Dr. DeRay did what's called a touch prep, where he just touched the pericardium to a slide, and it was able to visualize spirochetes on the slide. So when my chief said to me, you know, you're obsessed, and he was definitely getting ready to sanction me. And I told him, well, you know, her pericardium showed spirochetes. He backed off. He said, oh, this is a complicated case. So it's a damn good thing I was thorough, you know, because I don't know what would have happened. So that, in case you couldn't see it, that's the spirochete. With the treatment, also her pericardial effusion resolved, her pleural effusions resolved, her mentation improved, and she was doing good. And at that point, I discharged her from the hospital. And then what would happen is, if she wasn't treated, she would start deteriorating again. And at that time, Empire Blue Cross Blue Shield had not yet formulated policies about Lyme. And they had a medical director named Sherwood Miller, who was a very decent man. And whenever I could provide the information that explained what was going on, he would approve another couple, 3 or 4 months, or sometimes 6 months of treatment. Every time I treated her, she would get better in objectively measurable ways, okay? Not just my opinion. The physical therapist demonstrated that her gait improved, etc. Then around 1998, there was a change in policy at Empire Blue Cross Blue Shield. They brought in what they called the California Posse. So it turns out Empire Blue Cross Blue Shield was interested in transitioning from a not-for-profit entity to a for-profit entity. And in order to do that, I guess it was to their benefit to have a more profitable bottom line. And their accountants, Deloitte and Touche, told them, you need to issue more denials. And Richard Sanchez actually was in on that decision, and they made it more difficult. They raised the bar to make it more difficult to qualify for treatment for Lyme disease. And they said to themselves, well, the way they could sleep at night, they said to themselves, well, there's an appeal process. So if we deny it, they'll appeal, you know. But he realized that some people would never be able to negotiate that tortuous appeals process and might fall by the wayside. So for several years, I was really not able to treat her. And I had tried intensive oral, and it just didn't work. So it was like futile. At one point, I was able to have her spinal fluid tested through those research methods that I told you about, the Coyle and Schutzer's research methods. And so outer surface protein C antigen capture in spinal fluid was more than 7 times greater than the positive cutoff in her spinal fluid, okay? And also, she had evidence of Borrelia-specific immune complexes, IgG and IgM. Now, this came from the laboratory of one of the physician who consulted for Empire Blue Cross Blue Shield, and with the litigation, I was hoping if we ever got to litigation to confront that person with this, but because it was his research lab. But anyway, the litigation didn't go forward. It's a long story. I don't have time to go into all of the details, but due to various circumstances, she actually succumbed. She didn't really succumb to the disease. She succumbed to medical care. I tried to admit her to hospital, and I knew that she was a problematic case, and so I called for a meeting of the Medical Ethics Committee and the Quality Care Committee. And at that meeting, because she had been admitted and had been in the hospital, and Empire Blue Cross Blue Shield had refused to pay for her care, and the hospital ended up having to eat something like $200,000. So I knew that it was a problem when I admitted her again. And at that meeting, they had a medical ethicist consult by phone. And I'm there with my colleagues, and there's a different medical director at that point, who was actually a very decent person. The medical ethicist said the following: treating this patient was not a wise use of scarce medical resources. Okay? I was forced basically to discharge the patient from the hospital. And finally I finally found a nursing home at which IV antibiotics could be given. I don't do nursing homes, but in her case, I joined the staff so that I could take care of her. And meanwhile, we had met with the head of New York State Medicaid about her case to try to get them to approve treatment in a nursing home. And they gave me this whole, complicated system that at first I had to submit the request, and then they so meanwhile, she was admitted there. I did start IV antibiotics on her, but the nursing home didn't have a means to get reimbursed for the care. And the director of the nursing home asked me to discontinue her treatment while I tried to, then appeal to Medicaid to get approval. That turned out to be an incredibly frustrating bureaucratic process. I'm calling this one, that one, getting nowhere. In the meantime, she sustains a series of grand mal seizures. Meanwhile, seizure disorder was a part of her illness. Okay, she was on anticonvulsants. So they took her to the nearest hospital, which I didn't have privileges at. I'm expecting that, they'll adjust her anticonvulsants and send her back to the nursing home. Well, that didn't happen. It turned out that she developed a low blood pressure, and while she was there, and the doctors taking care of her spoke to the next of kin and persuaded the next of kin to make her a DNR, do not resuscitate. Yeah. And she's a young woman. She's like in her 40s at this point. And I know that she was compos mentis at that time because her best friend Rosalind was at the bedside, and Vicky mouthed to her, "I love you." Okay? So they withdrew care, and unsurprisingly, within a short period of time, she passed away. Okay. Meanwhile, she had already given consent for an autopsy should she die. And we tried to get the pathologist to perform an autopsy, and he refused. And he went by the administration of the hospital, and they backed him up. Fortunately, because of my contacts with Dr. Fallon, we were able to get the neuropathology section at Columbia Presbyterian to accept her case. And so they did the autopsy on her. This is the autopsy, first page of the autopsy report. The main finding was this: chronic Lyme disease with meningoencephalomyelitis. But the proximal cause of death, however, which is really important, was she had sustained a heart attack, probably during the seizures that she had, and nobody bothered to evaluate her. If a regular patient has low blood pressure, you're in the hospital, it's the physician's obligation to investigate why is the patient hypotensive. They didn't even do that. I don't even think they did an EKG on her, ever. So I've never said this before, but I think I'm going to say it. I've given some careful thought to it. Her death, really, it was a medical execution. And then the hospital would not allow, and then tried to block an autopsy, okay? This is from her brain, and it shows a vasculitis with dense infiltration of plasma cells. Again, that's a type of cell that often is seen with spirochetes. And we were able to have Klaus Eisenli, who's a dermatologist from Austria. He had a special method of immunohistochemistry, and he was able to show uptake in areas where she had this dense infiltrate. I also want to tell you that her tissues are being subjected to further study. She's one of the cases that are being studied by Dr. Fallon and his group, so there's going to be more to come. And if you think this only happens in adults, that's not true. This was a case of mine that was reported in a 7-year-old child. This 7-year-old child had a tick attachment on her neck, engorged, and the mom brought the child to their pediatrician and begged the pediatrician to please treat the tick attachment. The pediatrician refused. That was in the spring of, I think, 95 or 96. The next fall, she had, her teachers noted a change in personality. She used to be very engaged. They noticed that she was not performing normally, and then shortly thereafter, she developed what's called status epilepticus, intractable seizures, where she needed to be, she was brought to a tertiary care hospital where she had to be put under pentobarbital coma to control her seizures. Eventually, the parents brought her to Charles Ray Jones, who's probably the #1 pediatrician in the world for pediatric Lyme. He referred her to me for a spinal tap, which I did. And at the time of her spinal tap, she had 4 out of 5 CDC-specific IgG bands on her western blot at Stony Brook. And Dr. Jones started treating her, and she started getting better, significantly better, but she definitely had sustained a level of irreversible neurologic injury. At that point, the pharmacy benefit manager for the patient's parents' employer refused to authorize further treatment beyond a certain point. I think she'd gotten maybe 6 months of treatment, then he refused to authorize further treatment. She was getting better. The parents could not afford her treatment. Treatment was stopped. She started again having intractable seizures, and within a month of discontinuing treatment, she was dead. Okay. I do not know whether she had an autopsy, or if she did. I'm not privy to the results. This is Vicky. Unfortunately, I guess I don't have the sound. It's a video of her. I guess if it was my computer, we could do it, but I can't do it. Okay. I want to talk about the power of storytelling. It's very important in this field. Book authors, investigative journalists, bloggers, internet platforms, movies, cinema, patient personal testimony. I don't know how many of you might have heard Nicole Malachowski at the HHS working group. She's a fighter pilot who led a fighter wing, and she got Lyme and again was disbelieved, and she had a very, very powerful story to tell. Polly Murray, who was the housewife in Lyme, Connecticut, it was because of her pestering the Connecticut Department of Health that they finally sent somebody out to investigate. That was the beginning of Lyme disease. Pam Weintraub's book, Cure Unknown, excellent book. Ali Hilfiger's book, Bite Me, very good. Ali Cashel, Suffering the Silence, Chronic Lyme Disease in an Age of Denial. Katrina Macris, who's a homeopath, she actually got well from Lyme without antibiotics. And then Laurie Dennis's book, Lyme Madness, and again, Lyme Loonies from David Skidmore. And most recently, Mary Beth Pfeiffer's excellent book, Lyme Disease, First Epidemic of Climate Change. There are a lot of good things going on now, despite all the discouraging things I just told you about. There is a sense of community, of patients, advocates, philanthropists, constructive scientists, researchers, physicians, legislators, and enlightened public servants. Again, much that is positive is happening. There's some wonderful organizations, patient advocacy groups. I'm listing them all here. And there are others that I couldn't list them all. I want to call your attention to the Dean Center for Tick-Borne Illnesses at Spalding Rehabilitation Hospital. Nev Zubčevek is one of the co-directors. She's awesome. She's doing great work. The HHS Tick-Borne Diseases Working Group is also, there are many fine scientists, advocates, and I really highly regard and respect the service because it's a lot of work, and they're doing a great job. There's at least 3 top-tier academic research groups now that there is acceptance that chronic Lyme is real, chronic persistent infection is real. One of the most destructive things about the denial of chronic Lyme is that it has set back research by 3 decades. Now, these groups, Kim Lewis at Northeastern, Ying Zhang at Hopkins, Jay Rajadas at Stanford, and also Eva Shapi at University of New Haven. I didn't list her there. They're doing great work, and I'm very optimistic. We're going to have better methods of treatment. Trust me, we will. I've said for a long time that our methods of treatment for Lyme disease presently and the other tick-borne diseases are primitive, okay? Also, John Ocott's, what he calls it, his SLICE study, which follows patients over time, and Dr. Fallon's Lyme Research Center, and including the autopsy studies that he's doing, are going to be very helpful. We're on the cusp of improved methods of diagnosis, next-generation sequencing, recombinant antigens, microarrays for diagnosing multiple tick-borne diseases from a single blood sample. And we're going to have, we could have more direct detection, more focus on direct detection methods. There's this Lyme nanotrap that Dr. Fallon mentioned. I wanted to take a minute to mention the NIST membrane detection method. So NIST is the National Institutes of Science and Technology. They were charged, they were involved with Dr. Ocott's SLICE study, and they got specimens. And they found that using a method that they developed, which uses liquid chromatography and mass spectrometry, that the thing that correlated most with the status of the patients is this method, which detects, actually, it detects outer surface protein A antigen. It is, I would argue, is the modern day correlate of the Rocky Mountain Lab antigen capture assay that required electron microscopy. But this method, I would argue, is suitable for high throughput commercial uses. Unfortunately, for reasons unknown, it is sitting on a shelf. It's crazy. There are efforts at prevention. The Carey Institute in New York, Rick Ostfeld and Felicia Keesing are doing a neighborhood tick control method using bait boxes and entomopathogenic fungi, which Pat showed you that beautiful image of the tick basically being killed by this fungus, which is felt to be benign to humans and to other insects. They have a grant from the Stephen and Alexandra Cohen Foundation to do this over wide swaths of neighborhoods in Dutchess County, so that's going to be very interesting. I think as Dr. Fallon mentioned, Kevin Estfeld's CRISPR technology, the Lyme trials. The USDA has a 4-poster for area-wide control of tick vectors over broad geographic areas. I just want to point out that in 1990, I was invited out to CDC. And we had a great time out there. This was 1990, and I got to know many of the scientists out there, and many of them I remained in contact with and actually collaborated with for many years. And I would, regard them as my friends. And they're great people out there, okay? It's not the people, it's the policies, okay? Policies need to change. And in that regard, it might not be a bad idea for Bay-Dole to be revisited, because there may be situations where the private interests of federal grantees and agencies may conflict with the public interest, and there's got to be some remedy for that. Thank you very much for your attention.
Again, any other questions on later when we're finished, please put them in that box. They will get answered. I'd like to just say a couple of things, and then we're going to do the raffle. First, I'd like to thank the speakers, Dr. Brian Fallon, Dr. Bob Bransfield, Pat Smith from Lyme Disease Association, and Dr. Kenneth Liegner. I also like to thank Dr. Visconti for sitting in today, as many of us in Staten Island know him. He's our local friend. I appreciate my friends and family that helped me put this together today because, of course, something like this does not happen on your own. It's very difficult to do. I'd like to thank the Borough President's Office, Ed and Jenny, for coming today, Andy from Staten Island Cable and Television for doing this, and this will re-air on public access, and also, once it is digitalized, it'll be played on Lyme Disease Association's YouTube channel, and we'll put that link on our website when it does come up. I want to thank Pat Smith and Lyme Disease Association, our affiliate partner, for helping us with a grant for this event. I want to thank our community partners. Anthony from Alfonso's that we all aware of on the island. Anthony's a true friend. He said, you know, breakfast, coffee, cake, I have it. Don't worry about it. I thank him very much for that. Tim and his family from NutriMedics for donating the protocols. This event could not have happened without the cooperation and concerns of Richard and Lois Nicotra and the Nicotra Group. Again, this event is very difficult to put through, and without their cooperation and help, I would have never been able to do this. Call in from the Hilton, who arranged this party, and Frankie from Pro Show, who provided the video. And the most important thanks is to you guys. My whole reason for doing this is to bridge the gap for patients, to give back just a little bit. So if you all came here today, sat here, and got one piece of information you didn't have prior to coming here, then I feel I did my job. Because the job is voluntary, and it means a lot to see what I'm doing is translating into an answer for somebody. There's so much more out there, so much more we can provide and we will provide, and it takes the community. We're working all together in a larger area for this, and all I could say is, be patient, be hopeful. Let's leave the negativity where it was in the past, and let's see where we're moving forward. We have a lot of things to address. And with that, I want to thank you. That concludes Lyme Society's first annual educational conference. I thank you all for participating, and I wish you luck. God bless.